Guten Tag, meine Damen und Herren. Entschuldigung, aber ich lerne erst jetzt Deutsch, en français aussi, pardon, so everything is in English. I'm going to begin by reviewing, just to put a bit of perspective on this, how recently many of these issues have emerged. In 2010, 6 years ago, rather before the current so-called migrant crisis, I had a conversation with Richard Horton, editor-in-chief of The Lancet, about the possibility of doing a commission on culture and health. As a medical anthropologist, that quite interested me. And we discovered, looking at the publication record of The Lancet, that in 23 years they had not published anything on culture and had never actually supported such a commission. And indeed, the process, therefore, of putting together took us quite some time. It involved, let's see if I can get this to work, 27 authors, a multidisciplinary group, health humanities, clinicians, medical anthropologists, sociologists, social demographers, epidemiologists, global advisors, external reviewers. How do you actually review such a commission? Who can actually judge on the selection of topics for a commission that hasn't been carried out in such a long period of time? And of course, the Lancet's own internal team. And this was interesting because here you have a clinical journal that was trying to evaluate what was largely an interdisciplinary activity. And then finally, community focus group discussions, because we were quite interested in trying to figure out if we actually had the right topics to begin with. And we carried these out in the North Middlesex area, which I'll talk about in a bit, North London, Tottenham, Northeast London, Tower Hamlets, probably the most ethnically diverse as far as I know in terms of super diversity places, at least one of them in the UK and possibly in the world. As a result of that work, we divided the commission into four key areas. Communication skills, cultural competency, broadly speaking, communities of care, and I would like to build on Jenny's comments about alienation and the problems of superdiversity or hyperdiversity, where you have people who are not parts of communities. Integration and fairness, the whole question of health equalities, which is very pertinent to the focus of today's meeting. And then finally, this very tricky thing called human well-being, which I think is even rather hard to translate into German, let alone into other languages. But basically the idea of having a life that is fully realized, and to the capacity to engage in having the capability, the opportunity, the motivation, to use the behavior change language, to actually have a positive effect on one's own life. Now, we made 12 recommendations. I won't go over them. The PDF is available free online. But I'm going to focus today on the question of social services, clinical services, and psychological services. And I want to focus on the idea of culture for health. That is to say, not culture and health, that health and culture are rather different things, but the question of how we cultivate culture as a dynamic tool for enhancing health. And indeed, The Lancet enough agreed with us that when they published the document, this is what they said on the cover: the systematic neglect of culture in health and healthcare is the single biggest barrier to the advancement of the highest standard of health worldwide. It's a very bold statement. I'd like to spend the next few minutes trying to show you why I believe it is to be the case. The commission has been translated in a number of languages. It'll be available in German next year, and we're hoping that it functions somewhat as, at least as a foundation for debate, if not as a teaching tool as such. Now, that statement on the front of the Commission report raises a very big open-ended question, and that is the question of what is culture. And of course, as a Commission with quite a diverse group of people involved, we had to spend a great deal of time trying to figure out what culture is. And eventually we settled on this really quite simple and we think elegant definition, which comes from the anthropologist Robert Redfield, who did field work in the Yucatan in Mexico way back in the 1940s. And Redfield said that culture is conventional understandings manifest in act and artifact. Now, the trick here is the question of what are conventional understandings? Well, we tend to think of culture as things that we value, but of course, it's not only that. Culture are, of course, the identities we feel, but they're also the taken for granted practices, the things that we assume that because we do something a certain way, everyone else probably should do it the same way. In other words, they're the shortcuts that we take every day that we do take for granted about our own actions. And what this means is that culture is not restricted to things like nationalism, race, ethnicity, gender preference, and so forth, but it's actually something that we have to acknowledge that we all have. We all have set standards of practices that we live by, and how we participate and share those assumptions and how those align or don't align with assumptions of other people. In other words, how we align expectations is really a key to understanding what the role of culture is in health. And so we apply this term to a wide variety of values. So culture is this, of course, in a stereotypical sense, but it's also this. We talk about institutional cultures and we talk about healthcare cultures as well. Now, before you say, oh no, you're wrong, healthcare is one thing and culture is something different, I will remind you that actually culture is used regularly to describe institutional healthcare practices. So here's the Robert Francis Commission in 2013 when a few hundred people died because of malpractice in the Mid-Staffordshire NHS Trust in the UK. And people were anxiously waiting to find out who was the culprit, who had missed it. Was it nurses? Was it doctors? Was it repayment systems? And no, the commission report said no, it was the guilty party was the culture of the National Health Service, so the culture that ignored the priority that should have been given to the protection of patients. It was the culture that too often did not consider properly the impact on patients of actions being taken. So what we see here is that culture is actually something that needs to be understood at a wide variety of levels. And what we need to do is to figure out how do we build bridges between these various forms of expectation and these different cultures. Now, before you again critique this and say, well, are you being a complete cultural relativist? Absolutely not. I'm not judging on whether medical culture is correct and another one isn't. I'm merely saying that we have to acknowledge these levels of expectations. And indeed, the WHO has done just this. You'll remember back in 2014, and this was a CBS report, when Liberian police depart after firing shots in the air while trying to protect Ebola burial teams in the West Point slum of Monrovia, Liberia. Here, a crowd of several hundred local residents chanting "No Ebola" in West Point drove away the burial team and their police escorts. The mob forced open the Ebola isolation ward and took the patients out, many saying that this Ebola epidemic was a hoax. And of course, in the aftermath of that really quite embarrassing realization of the broad abyss, the couloir between these two expectations, the WHO itself in 2016, January 2016, in their document report on the Ebola crisis, said that they felt that it was necessary that the WHO now examine its own organizational culture, and I quote them. So this idea that culture is something that we all participate in is getting quite a bit of traction, and indeed, if you look at I've gotten to my next slide too quickly. If you look at the way in which culture is described, you begin to realize that in fact, once we look at it this way, we have a wholly different way of thinking about illness and how we treat illness. And what I want to do is I want to ask you the question of what happens when we ignore the social and cultural context of health, okay, and their effects on human behavior. And I want to spend just a few minutes looking at one illness, and you'll see where the cultural part of this fits in as I describe this. And that illness is diabetes. Okay? What you have here, I'm going to spend a few minutes with this slide. It's a bit complicated. But what you have here is an example of what is called the rule of halves. The rule of halves was originally developed for studies of hypertension, and it's meant to describe the steep decline in adherence among people dealing with chronic lifestyle diseases. Here we have the diabetic population. Currently in the world, that's 415 million people. That's a big number. If diabetes were a country, it'd be the third biggest country in the world after China and India. Okay, put that in perspective, all right? So you have the 415 million people. The rule of halves, the reason it's called halves is because globally about half of these people were diagnosed. That is to say, half of them fall into this area, which would be clinical care at some level. We know these people are in any case. Of those who are diagnosed, about half are in treatment. Of those who are in treatment, about half reach their treatment targets. And of those who reach their treatment targets, about half achieve their desired outcomes, okay? This is a terrible commentary on our ability to change this incredible chronic disease, which in fact, in countries like Mexico, will consume the entire healthcare budget within the next decade if nothing is done, all right? Now, when we look at this, this way, what we see is that these are people in treatment. These are people out of treatment here, okay? So out of treatment means their experience is only social and cultural or psychological. It's not medical because they've not even been diagnosed, okay? For these people, these are adherence issues. These are people in treatment, but for some cultural, social, psychological, economic, whatever reason, they're not able to reach their treatment targets. And then this group down here, these are the purely biomedical. That is to say, these are people for whom, no matter what their biological condition is, they're doing okay with the illness. So we don't really have to think about whether they're rich or poor, or they understand or they don't understand. They're doing fine with their illness. The problem is it's a pretty small number, okay? In the best situations, the UK, say, or Denmark, this number might be 30% diabetes. UK might argue for 40, but still that's not a very good outcome. In Mexico, that's 7%. In Indonesia, 1%, okay? Now, the important thing here is for everything above this, you have an experience that's socially, culturally, and psychologically mediated. Okay? At some level, the experience of every one of these people is somehow affected by that. And here, okay, the purely biomedical, what we might have to deal with in a hospital setting, okay, is actually a very small part of the experience. Now, the good news for hospitals is if we think about reframing our research paradigms, we can say, hey, look, we need a lot more research in other areas to get the burden off of the hospitals a little bit, because actually when you think about the purely biomedical part of this illness, it's not that big. And in fact, the whole picture gets a lot worse when you start looking at the pre-diabetic population. Let's just take the one key figure of risk factor of overweight and obesity, which is about 2.1 billion people in the world. It's 30% of the world's population. So here's the biggest country, third biggest country in the world. We put this against this, it looks like this. Okay, hey, here's your obese and overweight population. Here's the third biggest country in the world, and this comes down to just a thin line. It's like dragging a stick across the sand. Okay. The purely biomedical part. So what does this tell you? It tells us that we have to change our paradigm, and we have to change it quickly. Now, what's the proof of this? We ran some data analysis on publications. I'm not going to spend a lot of time on this, but think about our own biomedical prejudice and the question of, can we keep doing what we're doing? Okay, we went on Web of Science, and we found out that less than 10%, 8.16% of the publications on diabetes had to do with the social sciences and humanities, about the experiences of many of the people that we're concerned about. Scopus, 2.8%. So there's 2.8% of the scientific, what we would call the evidence base we're all supposed to go to. Only 2.8% of that has to do with what in Mexico is 93% of the experience, or in Indonesia 99% of our experience, okay? So we have to shift this paradigm and create this new evidence base, and we need to do it now. And the reason we know we need to do it now is because it's not just the academics who are saying this. Here's the World Health Summit. You can see right here, migration and health is right alongside technological innovation, infectious diseases, MSRIs, all the rest of it as central topics for their annual meeting. Okay, now I'm not going to say more about that, but I'm happy to answer questions. I want to move on and point out that this concern is also reflected very clearly in broader agenda. Here's the European Commission's Health and All Policies agenda, and you see here that we're supposed to be integrating health concerns in all of these areas. And I would suggest that it's incumbent upon the health industry, the health providers, to push for this agenda, because it's saying, look, folks, you have to start back in these places to think about health and well-being. Otherwise, we're going to be overwhelmed, as we already are, by the effects of you're actually not doing that. Okay, now, this lack of evidence has a really significant impact on the misuse of healthcare funds. I'm just going to give you one example of this, but I think it's enough to show you what I'm getting at. If you look at the UK, in 2014, the national health budget, NHS budget, is about £66 billion. About 10 billion of that goes for diabetes-related mortality and morbidity. That's 15%. 800 million directly to diabetes care, but 80% of the funding around diabetes is on related complexities. Now, you think about it, these are just numbers for us, but let's put it in perspective. Okay, if 10 billion of the 66 billion is spent on addressing diabetes-related mortality and morbidity, and you only have 30, maybe 40% adherence rates, that's 30 or 40% of that's going where it's directed. That means 6 to 7 billion pounds annually is not hitting its mark. It's a lot of money. Okay? It's a lot of money, and part of the reason I would maintain for this incredible misdirection of funding is because we haven't actually come to terms with the social, cultural, and psychological risk factors. So the unavoidable fact here is that I think we spend much of our effort on only a small part of a really big problem, and this itself is a cultural choice. Okay, it's a value judgment we make about health and well-being. I want to talk about well-being towards the end of this, but in conclusion for this introductory part of my talk, I think we have an opportunity to build a new evidence base that will not only improve migrant care, but also improve health care for everyone. And what I will try to show you in the final part of my talk is that migrant care is a small part of other much larger questions. So what I want to do is end with just three examples, three concrete areas that are in need of work. Social sciences, first of all. Social services and sciences as they relate to studying social services, work's needed to understand the relationship between the cultures and values of those who provide services and those who receive them. As I said before with respect to WHO, CDC in Liberia, but also 2015, now we have an expert group that I'm involved in at WHO Europe looking at the cultural context of health and well-being measurement, and we're coming out with an advocacy document this spring, which will try to define some of the parameters within which we feel these problems can be more effectively addressed. Clearly, we have things like new apps on phones, which are helpful to some people and very useful, but as we've seen, people use them differently. Sometimes they misuse them. Sometimes they take actions on wrong information. So we have to do a whole lot more than that. And what we've been involved in is, and we've done this now, carried out these vulnerability assessments with well over 1,000 people globally. But what we're doing here is we're trying to understand, first of all, what are the utilization of formal services? Do people use them? Do they not use them? Are they use them intermittently? Are they short? Do they have short and long-term impact? Do they help some people and not other people? What are people's perceptions of them? Many of the things that Jenny brought up in her talk. We're looking at the community domain, which is what we would traditionally call social and cultural capital. How do people innovate? Can the innovations be scaled up? Are they good innovations, bad innovations? Bad innovations like gangs, okay? Gangs are an innovation in the absence of social infrastructure, all right? And then finally, and this gets to the point that Jenny beautifully brought up in her talk, is we need to look at the vulnerability domain, because in global context, you have people who actually within communities do not have capability, opportunity, or motivation. If you are the only Eritrean in amongst a group of Syrians, you're just as alienated as you would be were you the only Syrian among a group of Eritreans. So who's actually left out? And the point is that because people are left out, oftentimes they're so struggling with that capability threshold, just they can't be their own advocates. We need to actually go out and find those people. So what we have to do is find somebody who fulfills our characteristics, our criteria for vulnerability, that for example, the UN's characteristics, children taking care of children, grandchildren, children looking after children, children from mixed lineages living together, those sorts of things. And we need to go to them and then find people who are more vulnerable than they are. Can you tell me somebody who's more vulnerable, who shares your same experience, and you characterize that level of vulnerability? We've done over 100 people we've trained to carry out this kind of work, and what our idea here is the work actually is a 1 to 3 hour interview, which we then code. We get the data from the interview, so we're not just looking for qualitative examples, we're actually trying to quantify the qualitative data, and I'll get that in a moment. But the goal here is to bring lived experience, the actual experience that accounts for that difficulty that we see in the rule of halves, which you can apply to other illnesses, okay, to bring that to the level of evidence. How can we actually create evidence out of that will convince people who are making policy decisions why this is important? And what we end up with is something like this. We end up with, and I put this in the context of hospitals for equity, we end up with the need for a new evidence base. Now, I don't have time to talk about this in detail because I don't have much time left at all. But the point that I'm trying to make here is that if you look at any one of these, you can look at any one of these biological risk factors, social risk factors, geographical, cultural risk factors, and what we do in science is we eliminate all the variables, don't we? Because we're trying to control for the effect of something by eliminating everything else and doing a control. Well, we all know that life actually is not like that at all. In fact, these variables exist multiply in a person's life. And furthermore, they compound your experience of illness. So, for example, you can start here with age. I'm a male over 50 years old. I don't have health insurance. I have a migration background. I've moved from a rural area to an urban one, say in Mexico or to Europe. And then I feel stigmatized because of my appearance. And you can put these together in any way you want. But the point is, you actually, if you do it this way, you not only can build what we call a real live case definition of vulnerability, but you can actually put numbers on that. You can actually quantify that to a certain extent. Now, before I show you how we do that very quickly, let me show you the impact of this on migration health. Let's take the example of Denmark. In Denmark, healthcare is not only free to everybody, healthcare registration is mandatory by law. So you're breaking the law if you haven't signed up for healthcare provision, okay? Now, in Denmark, going back to the diabetes data, because I'm trying to stick with that for this talk, well-educated people of Northern European descent, that number drops to 2.1%. And if you then look at unemployed undereducated residents of non-European descent, that's 18.5%. That's 9 times higher in a country where healthcare registration is mandatory. So something else is going on there, okay? Something else very important at the level of culture is going on, and I believe that if we're going to address this problem, it's our obligation to understand this. And of course, the way we understand it is that we can create other case definitions. Somebody with high BMI, with a low level of education, who travels a long distance to work. I'm a Mexican worker and I live outside of Mexico City because it's too expensive, and have a very low activity level because I spend 6 hours a day in a pickup truck getting to and from work. Okay, and what we can do is then we can compare this, because all this data is coded, and we can actually put percentages on low income or unemployment, and what that tells us is something equally interesting. Okay, if you look at low income, unemployment, no medical insurance, low ratio of reimbursement, financial constraints, which we would think about if you look at just the social determinants of health literature, you're going to say that's a major problem of inequality. Well, That's 35% of the experience of the people we interviewed. Now, we may think they're unequal, but they may not, okay? I mean, people coming from Aleppo to a refugee center may actually feel that the health care they're getting is relatively better than what they had before. Doesn't mean that they're not, in our view, that they're not living unequal experiences, but understanding what people's perceptions are is incredibly important. At the same time, if we go down here to get to what just came up in the last talk, this key problem of isolation, lack of community support, lack of friends and family support, lack of social support, 93%. Okay, so what does this tell us? It tells us that we understand the relevance of both of these, but if we have to think about where we're going to put our pounds and pennies and francs, perhaps we have a better shot at putting it in a place where it's going to have some effect. Okay, I won't say more about that. I can talk about it in the questions, but I want to say just 2 words about clinical services and something about psychological services. Now, one of the things that I've noticed in this conference yesterday and today is that there are a lot of really interesting innovations taking place, and what's desperately needed is some kind of a context that was alluded to in our introduction wherein people can actually compare best practices. This is a very interesting example because it's the North Middlesex where I mentioned earlier where we were working, and what they actually found out was that all these misuses of acute care that Jenny were referring to, that the technological challenge of poor information and wrong information and also of complex socially mediated variables had changed dramatically the effect of accident and emergency experience. So rather, when I worked with the homeless for 2 decades, you had people who had health care and they were on the NHS, and you had people who had nothing and they were a blank slate. Now you have somebody whose whole experience is mediated by this, and they're getting things from abroad, and maybe they buy steroids online, and they've done that for the last 6 years. You know, you have all sorts of people walking in, and they're complex cases walking into the accident and emergency. So what the North Middlesex did, which I think is quite interesting, they did 2 things. One is they divided their accident emergency in half. And what you see here are doors. They almost look like barn doors. Okay, they're primary care offices, and there's a door at the other end. You go in, and either you're going to go into the hospital or you're coming back out with the meds that you're given. And the acute care is on the other side of the building. Okay, it's completely separate. Why? Because 1 in 5 people who come to the North Middlesex Hospital can't identify a primary care provider. Okay, they're not on anybody's record. They're just walking in with everything and anything. And the question of how we adjust to these things, I think, are lessons to be learned, because what else the North Middlesex found out was that because they're in a poor part of London, when they rebuilt their hospital, they put a coffee shop in the middle of the hospital. It's a Costa's or one of these chains. And the point is that this became a social center as well. Right? It became a place where people would come socially. And what the effect of this was that people actually began more to trust the hospital environment than they previously had. So what the hospital is realizing, to put this in a nutshell, is that health is a matter of not having signs and symptoms of sickness, but well-being, on the other hand, means feeling a sense of belonging that allows you to care for your own health. It's important as health, because without well-being, a person feels isolated and helpless, don't we? We know this from the long-standing research on mortality and morbidity. I'd get back to Jenny's talk, that people who migrate alone always have much higher levels of mortality and morbidity than people who migrate into families. We know this. There's a lot of data that shows this indisputably. We also know this, actually, to get back to the question about mental health in Switzerland, we also know this from research on depression and suicide, that eliminating alienation is a key driver to better health. So how do we actually deal in these significantly diverse contexts that are completely unstable, like new and emerging megacities where you have massive migration? 70% of the world's population will live in cities in the next 30 years. How do we deal with these higher levels of alienation? And this is where I think, when you look at this statistic, you understand that migrant needs are exaggerated versions of what we all need. Now, I could say, again, more about that, but I'd like to get to the last one. I know I only have a minute left. 2 minutes, I'll make it, okay? And that is the question of psychological services. And this is new work that understands patients' health behavior. Those of you who are psychologically or psychiatrically trained know about the cultural formulation. It's in DSM-5. It comes from some early work by some colleagues of mine at Harvard years ago. And what it does is it basically asks the clinician to ask questions. What do you call this problem? What do you believe is the cause of this problem? What course do you expect this problem to take? How serious is it? What do you think this problem does inside your body? How does this problem affect your body and your mind? What do you most fear about this problem, and what do you most fear about the treatment? In other words, to gain information about the patient's point of view. Now, this has been developed, further developed. This has not been in DSM-5. It may be in the next one because there's a controversy around this. This is the Bloomsbury cultural formulation developed by some colleagues of mine at University College London. And what this does is it ups the stakes significantly because it asks the doctor or the clinician to offer the patient the same information. My name is David Napier. I was born in Pittsburgh, Pennsylvania. I moved to the UK in 1980. Okay. In other words, to start to develop a dialogue, a genuine dialogue between an alienated person and another person who may actually also be in their own way somewhat alienated from the social context in which that clinical encounter is taking place. Now, I know you're all asking me the big question, which, how can we afford this, right? And here's where I think we, as hospitals of equity or for equity, where we actually have to be proactive and political about pushing a different agenda. Now, our assumption here is that clinical time, we have to reduce clinical time to, we are just heard 6 to 8 minutes, 9 minutes, to make healthcare affordable. And how we're going to do this is with online clinical encounters, self-help, smartphone apps, telephone consultations. Now, all this stuff, there's no question that all this stuff is important and it's very helpful. However, if you listen to patients, people like you and me, it becomes clear that the personal, social, and cultural context of health, these are actually what people find most missing. It's actually what they feel, by and large, is likely to enhance their own health and well-being. And this is not only for migrants who have less or no care, but it's also the case for everyone, and especially those of us who feel alienated psychologically or otherwise. Now, you say to me, well, how do we actually go about doing this? Well, the first thing we do is we go back and look at what we already know and don't reinvent the wheel. This is a study done by Hampton in 1975, looking at relative contribution of history taking, physical examination, laboratory investigation to the management of medical outpatients. Okay, and I don't know if everyone can see it, but what they did was they divided the clinical encounter into case history, physical exam, and medical tests. Now, I haven't put percentages here for a reason. I want you to guess. First of all, in which of these do you think most often the accurate diagnosis is made? Anybody want to take a... Yes, exactly. Okay. It's the case history. And in fact, it's not only the place where most of it takes place, it's the place where almost all of it takes place. Right? 82.5%. And what they do is they went back, and after the diagnosis had been made, they say, is this an accurate or an inaccurate diagnosis? In almost 83% of all the cases, the accurate diagnosis was made in the case history. Now, this begs a question, what does that actually mean? Well, we all know that taking an accurate case history doesn't take 6 to 12 minutes. The gold standard that most of the people looking at cost benefits of clinical encounters and clinical care, it takes 25 to 45 minutes. And indeed, this is why we, in our recommendation number 5, say that clinical culture should be reshaped. And I would actually invite all of us who are in healthcare to go out and re-examine this in the context of smartphones and all the other medical innovations and technologies that have come along. Because I wouldn't be surprised if it wasn't a whole lot different. And if it isn't a whole lot different, we ought to be able to put a number on that. And if we then look at the fact that much of our healthcare investment goes to the last 6 months of life, we had an interesting conversation yesterday where, of course, in some illnesses this isn't the case, it actually tapers off. But nonetheless, we spend a huge amount on acute care. There's no denying that. Okay, that is to say the treatment of morbidity, disease, rather than thinking about how we build health, cultures for health into care, we get a sense of potentially what might be gained. And I'll bet that maybe the pharmaceutical companies wouldn't be happy about this, and maybe the people who make medical devices wouldn't be happy about this, but I bet the insurance companies would, if you could quantify this, because I would wager that you'd find that it would cost less in the long run to actually spend that time that patients indeed need. Because we look at the cost of clinical encounters rather than the long-term cost of the healthcare system. And of course, the problem is that all these problems, the health and all policies that isn't there, end up where they end up in the emergency room with the hospitals having to take care of them. And of course, as we've seen, the hospitals that do good at it, what happens? They get more work because people know they can do it well. So this has to turn around somehow. And I would argue that the way it will turn around is to acknowledge the determining effects of culture and to create a concept of competent health care that, first of all, focuses on enhancing long-term health across the life course. That is to say, well-being, and in particular the sense of belonging, if you believe that data we were able to accumulate with over 1,000 people that suggests that 93% of their experiences are marked by alienation, and that appreciates the cultural difference enough to create some kind of sustainable future for the diverse world we inhabit. So thank you very much.